everyone, and welcome to the Surgical Ergonomics podcast, where we will be discussing everything related to surgical and procedural ergonomics, the people, ideas, and technology that will help enhance your physical wellness and career longevity. I am your host, Geeta Lal. I'm an academic endocrine surgeon, speaker, consultant, and surgical ergonomics coach. Having experienced work-related musculoskeletal injury myself, I am committed to increasing awareness of and developing solutions to counteract the impact of poor ergonomics on the professional and personal lives of healthcare workers in procedural areas. Today's episode is sponsored by Q Optics. Surgeons, your neck shouldn't pay the price for precision. It's time to demand loops that are built for you. Q Optics is more than magnification. Custom crafted through the lens loops engineered and tailored to your unique facial structure and surgical posture. The ultra lightweight titanium build eliminates pressure points, red marks, and the chronic neck and shoulder pain caused by heavy, bulky, outdated optics. With the exclusive TrueFit measurement system, each pair is precisely tailored to your unique facial structure, delivering a customized, stress-free fit and all-day comfort. The Ergo Direct Vision loops with up to 60 degrees of declination keep neck flexion under 15 degrees, or go zero flexion with the Ergo Angle Deflection loops for a straight-ahead gaze and complete ergonomic relief. And with crisp edge-to-edge clarity within an expansive peripheral view around the telescopes, your field stays wide and unobstructed. Transform your OR experience today with a 45-day trial and exclusive pricing for listeners of this podcast. Visit qoptics.com/Dr. Lal to learn more and schedule your demo with a local representative. And again, don't forget to use the code Dr. Lal to claim your discount. Your work demands precision. Your body deserves relief. Q Optics, designed for comfort, built for performance. By the way, Q Optics has also provided us with an Ergo Angle Deflection loops and headlight combo giveaway. The details will be provided at the end of this episode, so stay tuned. Hello, everyone, and welcome to another episode of the Surgical Ergonomics podcast. In today's episode, I'm really excited to have as our guest Dr. Sanjay Yadav. Dr. Yadav is a breast, thyroid, and endocrine surgeon at NSCB Medical College in Jabalpur, India. He's a pioneer in low-cost innovations for breast cancer and endocrine surgery and has led a lot of work to make advanced surgical care accessible in underserved areas of the country. He's an international awardee and educator and is deeply committed to research, mentorship, and health equity. Hello, Sanjay, and welcome to the podcast.
Hi, thank you, Geeta. It's truly a pleasure to be here, especially after hearing to all the previous podcasts. I really enjoy them and I share it with my colleagues and surgeons from local area. So everyone gives a great feedback. So it's truly an honor to be here.
Of course, I've been wanting to have you on the podcast for some time, so I'm glad that we could both make the time today.
Yeah, right.
So Sanjay, can you tell our listeners a little bit about yourself, including kind of where you grew up and what's your training background and how you arrived at your current role?
Yeah, so like I grew up, my hometown is near to Varanasi.
Oh,
It's
okay. Kashi,
yeah,
old time, one of the oldest
yeah,
cities in India. Okay.
yeah, Kashi. So, and I did my medical graduation from Mangalore, way down south,
Mm-hmm.
and,
Mm-hmm.
and MS surgery residency in Ranchi, Jharkhand, which is kind of central part of India.
Mm-hmm.
Then training in breast and endocrine surgery at Lucknow, which is not part of India. So I have covered almost entire India for my
Right.
education. Yeah.
Right. Now you need to do something in Kashmir and we'll be covered.
Yeah.
All right.
So after that, I joined here at Jabalpur, which is
Okay.
in central part of India.
Okay.
And I currently work in a high volume unit, breast and endocrine surgery.
Mm-hmm.
And we, as you said, we are trying to bring world class, low cost surgical care to underserved patients in this region, kind of doing robotic quality surgery on bicycle budget.
Well, that's a good way to put it. But I see some of the work you've been doing, obviously your publications, and I also follow your posts on various social media. And I encourage listeners to tune into some of Dr. Yadav's posts as well, because the description that he just gave you, world-class care on a bicycle budget, is really true. He is providing world-class care to these very remote areas in India, and he's working at government facilities, which means, it has to be low cost, right? They don't have the budgets of kind of major private institutions that we see, in the United States. So kudos to you for doing that. And I'll make sure I include all your social media information in the show notes for this episode so people can get in touch with you directly. So,
Thank you, Geeta.
yeah. So, Sanjay, I also wanted to kind of follow the theme of my previous podcast episodes and ask, how did you become interested in surgical ergonomics? Because that's what we've been talking about on the podcast. So, I'd like to hear a little bit about your story, or as much as you're comfortable sharing with our listeners.
Yeah, so I think my neck actually discovered surgical ergonomics way before my brain did. So, like during my residency, it was like I never heard of this word
Mm-hmm.
ergonomics.
Mm-hmm.
It was only during my fellowship at Lucknow we came across some things like we used to do long breast surgeries and thyroid surgery with neck dissection and all. So that time, our professors used to like tell us about like ergonomic postures and all, but it was not kind of major thing. And so I started developing this neck pain. I had to take break during surgeries because of neck pain. I had to apply some topical diclofenac and all. So
Mm.
during that time, I started searching about like solutions and if there has been done anything on this. So that time I stumbled upon this interested group of surgeons and which were led by you. So at that time I joined the group and I became more and more aware about surgical ergonomics. That is how I came upon this.
Wow, that's very interesting to hear, because I knew you had joined the sort of interest group that then became the Society of Surgical Ergonomics, and we've been kind of interacting through that mechanism. But I hadn't realized that you had developed symptoms during your training years, in fact. And, I think just these last couple of minutes, you've highlighted some important things that I want to point out to our listeners, right? So, one is that the experience of pain and other symptoms related to our work, which is operating and seeing patients, is quite common, right? And it's not unique to any specialty, and it's not unique to surgeons in particular locations. This is a universal problem. And you were doing your training in India, and you were hearing about it from your mentors. I'm guessing your discussion with them about ergonomics was, well, you should stand up straight and maybe take breaks, because you were already learning to do that, right? Stand up straight was my ergonomics education. No one ever taught us about other things, correct?
Correct.
Yeah. I'm so grateful that your mentors at least were telling you about taking breaks and things like that. And the second point that you very eloquently highlighted was that symptoms actually start early. They start during training. When we look at various studies, almost 80% of trainees in any program will report symptoms. Sometimes these start in the first 2 years of training, and they continue to get worse, right? Because as we do more and more surgeries, and as our bodies age, so we start really experiencing injuries in our 40s and 50s. So
Yes.
how many years had you been in practice when you kind of joined the interest group? Please remind me again.
So I was, I think, 1 or 2 years into my practice.
Okay, okay.
Yeah.
So still very early, but you were already experiencing, like you said, and you required, you were doing self-care, right? I say ibuprofen and coffee is standard surgical diet, but you were using topical diclofenac as well, so
Yes.
you were getting
Because
treatment.
because I have migraine also,
I
so
see.
it used to get worsened because of my neck pain. So
Okay. So, I know that once you joined the interest group that then became the society, you were interested in looking at ergonomic awareness among trainees and attendings in India, right? And you organized a study and got various people mobilized to do it. So I was wondering if you could share details about why you wanted to do this and how you went about doing things and what did you find?
yeah, so I'm glad that you asked it. So like I used to have this pain. I still have, but it is quite like now not so much. But no one around me told me that he or she experiences such kind of pain, or like every other surgeon looked perfectly normal to me. So that is when I thought, ki, okay, let's do a survey and see what is actually happening.
Mhm.
So we did survey of the trainees. So I think over 70% of them said they experience musculoskeletal pain. So while operating or after the surgery, and majority of them were not aware about ergonomics. They did not know the meaning of the word ergonomics only. So that is what made me think, okay, let us do something for that. And that is when we organized webinars in collaboration with you and Society of Surgical Ergonomics, and they were pretty effective. And we try to do it regularly. So residents are quite like they are aware of the ergonomics, and they try to implement it while
Mhm.
they are
Mhm.
operating.
I see. So, thank you for highlighting another point, which is universal, which is that there seems to be such a stigma attached to surgeons experiencing pain and symptoms, right? Like no one
Yeah.
talks about it, and so you feel alone. Like you, I felt when I was experiencing the worst of my symptoms, I also wondered, like, why isn't anybody else experiencing symptoms? Is something wrong with me? And then when you started to talk about it, and you did this survey anonymously, obviously, you realized that 70% of trainees have symptoms.
Yeah.
And then how many of the attending surgeons in your study had symptoms?
I think over 75%.
Okay, so pretty similar numbers, right? So you were not alone. Okay.
Yes. Yeah.
Yeah.
That was a comforting point actually.
Yeah. And for our listeners, I'll let you know that what Sanjay is talking about in terms of the collaborative study that we did, we essentially replicated what we had done at my institution. Because this was still early days in the pandemic. And so
Yeah.
we did like a long webinar instead of multiple webinars. We did one kind of an intro to ergonomics, which is what I talked about. And then Dr. Claudia Corwin, who's an occupational medicine physician, and Barbara Van Gorp, who's a physical therapist, were also part of this webinar series, and we did this remotely. And then Dr. Yadav followed it up with a post questionnaire, and he took it a step further. He just didn't do a post questionnaire after the intervention. He actually followed it up a few months later with another questionnaire to see if there had been implementation of kind of the things that people had learned in the webinar. And we talked about ergonomic best practices, essentially, which you've heard throughout this podcast series. And so, Sanjay, I'm curious because I've not done a study yet looking at kind of how this translates into action 3 months, 6 months, 1 year down the road. So I was wondering if you could share with our listeners, what did you find, and did the resident in your follow-up studies, did you kind of learn what was easy to implement in India, what wasn't so easy to implement, what were the barriers, so I wonder if you could share some of those details.
Yeah, so like as you said, In our setup, like majority of attendings and majority of residents, what we try to do is kind of compensatory choreography. We try to
I
adjust our
see.
body to
Uh-huh.
the operative room setup,
Which is kind
right?
of opposite of what ergonomics definition is, right? Yeah.
Yeah, yeah. So the major takeaway from our survey, then webinar, then follow-up survey was that we need to make ergonomics as essential as hand hygiene,
Mm-hmm.
and without waiting for an actual MRI to tell us that we need
Mm-hmm.
to focus on ergonomics. When we followed it up, so the impact of these webinars persisted for long time. Like
Mm-hmm.
try to implement simple things which they could uh,
Mm-hmm.
in in their operative setups. So the simple things which we implemented is kind of adjusting the table heights,
Mm-hmm.
then using the foot mat and adjusting the OR lights and all. And what important and simple thing which I noticed made a big difference was taking breaks in between
Mm-hmm.
these surgery.
Mm-hmm.
So that is kind of routine, at least for me and residents who are operating, assisting me during surgery. We always try to take a break after some time, 45 minutes to 1 hour of surgery, and repeat it if surgery is prolonged. So and then in between do the stretches like neck exercises and arm stretching exercises. So these are quite simple but very effective techniques which can be implemented anywhere.
Right, right. No, I'm so grateful that you've highlighted these findings because I think, when we talk about these things as in the society and elsewhere, surgical kind of ergonomics, our environment, so our instrumentation does play a huge role. But like you pointed out, you have to start with the basics, right? Which is how are you actually doing your day-to-day work? I agree that
Right.
we have to tackle kind of organizational things and instrumentation things, but first we have to tackle how we do the work. Even with these brief kind of couple of webinars, you and perhaps the residents and your other colleagues were able to take away things that can be implemented easily that can make a huge difference. So
Yes.
I'm going to push you a little bit further into sharing some more details because I think this is really important. So, during the webinars, we tell people, okay, so when you're going to take a break in the operating room, you can take a break or you can do stretches or you can do both. And you highlighted an important point that usually it's recommended to take a break at least every 45 minutes. Did you end up using something like the OR Stretch app that we talk about in the society as well as on my podcast? Or did you end up using exercises that you had learned from Barb or the internet or your own physical therapist? So tell me what people did.
Yeah, so like for we began like using these breaks every after 45 minutes or 60 minutes.
So using
And
the app, using the stop clock in the app, or no, you just how, yeah.
just if during our initial part, we just said ki, okay, we will take a break after 45
Okay.
minutes, after
Okay.
60 minutes, right?
Okay.
So I did share the OR Stretch app with my residents, and many of them use that
Mhm.
app. But like majority after some time, we develop a tendency
Right.
to do those things on our own.
Hmm.
So like we have tendency, like I have developed a habit to do neck stretching exercises whenever I am free. So
Right.
yeah, so those things have happened. And opposite to what many people think that taking breaks and all may increase the operative time, but in my opinion it does not. Actually it decreases the your recovery time from surgery. So these are really very effective exercises.
Right. No, I agree with you that contrary to what we think, that, they do actually improve your operative efficiency and definitely
Yes.
improve your physical well-being, taking breaks and doing the stretches, when you have time during the surgery. And sometimes people say, well, where? And we said, well, there are natural breaks in the case, right? Maybe you're waiting for a pathology result or some blood work or whatever, you're waiting for PTH levels. That's a good time to take a stretch, right?
Yeah.
You're waiting for frozen section. And I didn't believe it until I started doing the breaks just like you. And I realized I didn't hurt after a long combo bilateral neck dissection, central neck, total thyroid case as much the next day if I took breaks and stretched. And more importantly, the last part of the case, the neck dissection went faster. As you said, you're
Yeah.
more efficient because you've given your physical body a break, and you've also given your brain a break, because that's a whole other field called cognitive ergonomics, which we will explore in another episode of the podcast.
Right.
But those two things make are equally important, not just focusing on the physical.
Yes, totally agree, Geeta. And these are so simple things, and we are not aware of them. And I am really thankful to you and Society of Surgical Ergonomics that you are spreading this message everywhere.
Okay, well, we're trying, and thank you for helping us too. This is, really great to hear. Now, I want to ask, I remember when we were doing the webinars, you had mentioned that, you don't have the same access to, you don't have as many physical therapists or occupational therapists. So it was, even if you were in pain, you weren't sure where to go to seek help if you didn't need like a surgical intervention or something. So has that changed any since the last few years? Are there people interested in working with you now as surgeons, in terms of not just surgeons, maybe even operating room nurses and scrub techs, because they also have injuries? So that was one question, do you have access to physical therapists, etc. now? And then the second part is, what did your OR nurses and technicians think about this when you were implementing breaks? Were they interested in joining in? How did that go?
Yes, the first part, unfortunately, we still don't have access to physiotherapist and all, and we rely solely on what you people teach us or what we read
Mm,
in publications and all. So, regarding like the overall OR setup, all the residents and nurses, everyone is quite happy when we take a break.
I
So
see.
yeah, so everyone gets time to relax. Majority of them try to do the stretching exercises, and also they are quite happy. So, and it is kind of a positive way of implementing things
Hmm,
where
hmm.
like they are not worried about it will increase their OR time or we are delaying the surgery. So those things are not there.
Hmm. So the OR administrators didn't create an issue when they saw you all taking breaks and stretching in the OR?
Yeah, fortunately, that's not an issue for us.
Okay,
Yeah.
all right. So your nurses join in, and do your anesthesiologists join in as well?
Like not so much, but few of them are quite interested and they definitely like try to join.
Okay.
But I think anesthesiologists are most ergonomic in their like they follow ergonomics best. So I think
They
they
get to
cannot.
sit. They get to sit.
Yes.
Okay. So this is all kind of really enlightening to hear, because we always wonder, all these things that we talk about, like, can they actually be implemented outside of our own settings, and you're telling me that this is possible. But, just like for us, I'm imagining things weren't all hunky dory, right? Like when we try to implement things, there are always going to be barriers, and sometimes there are barriers from unexpected things, or unexpected quarters, I should say. So, if you can share some of the challenges that you had in implementing these basic ergonomic things, like getting OR mats. For example, sometimes we face pushback from infectious disease, I shouldn't say infectious disease, but infection prevention people, in the OR settings, sometimes administrators, etc. So I wonder if you could share some of the challenges that were faced kind of at the resident level, trainee level, as well as the attending level. And, how did you deal with these challenges and, share any advice you might have for people trying to implement similar things who are maybe not in North America and maybe are in low resource settings like you are?
Yes, so I'm glad that you asked that. So as you said that the major challenge itself is low resource setting.
I
So
see.
there are
Yeah.
always, yeah, financial constraints like to procure the mats or other things. So but we like try to procure them on our end only. Residents also try to procure them if they think it is like helpful to them.
You mean
And
buying them personally? Is that what you mean?
yes, yes,
Okay.
yes,
Okay.
yeah. So they are not very costly. So I
Mm-hmm.
think, but
Mm-hmm.
they help us a lot. So these are simple, quite cost-effective interventions.
Mm-hmm.
And
Mm-hmm.
other things are like in our OR, especially our endoscopic monitors are set at a predefined height. They are
Because
not
they're
like
on a tower.
tower. Yeah,
Yeah.
yeah. So they are one thing which we are not able to change. So that is one of the barriers. So these kind of simple barriers are there, but that is why taking breaks in between is one of the I said is one of the most effective intervention that
Mm-hmm.
we implement in low resource setting.
Yeah. And it's
So
in your control, right? It's zero
yeah,
cost. You can do it. Yeah.
yes,
Yeah.
right. Yeah.
Well, it's interesting to hear that you had to purchase the mats yourself. For our listeners, there have been numerous studies over the years showing an improvement in fatigue and, pain, both lower limb and lower back using anti-fatigue mats. But, the studies were kind of mixed. But more recently, there has been a kind of randomized trial, if you will, published that showed not only reduction in pain and fatigue among surgeons, but also other OR personnel. So this is not just something that, it's yet surgeons being a diva group demanding, yet another thing, yet another piece of equipment. It's really for the whole wellness of the whole OR team. And I think it's important to highlight that, and that everywhere it is compared to a lot of the instrumentation and new technologies we look at installing in operating rooms, this is a very low cost intervention.
Yeah.
I do want to share with you though, Sanjay, just in case you feel like, oh my gosh, we have to purchase these in India and other places they don't. I will share with you that some of the surgeons in the Society of Surgical Ergonomics have had to purchase their own mats, when they're
Okay.
working in uh, countries where surgeons are, for example, independent practitioners. Example in Canada, they're not always hospital employed, and so surgeons will do the same thing as you have. They have purchased their own mats and put their name and OR number on it, so it shows up to their OR. But I am curious to hear whether you got any pushback from infection prevention, because that seems to be the biggest or the most frequently encountered barrier to using anti-fatigue mats. So I'm very curious to hear what your experience was.
No, fortunately, we did not have any pushback from them. So that
Okay.
was the thing. Yeah.
Yeah. Yeah, whenever I get pushback, obviously I share the data, but I always sort of end the discussion, at least from my side, by saying, well, it can't, the anti-fatigue mats can be wiped down, and wiped down anti-fatigue mats can't be any more unclean than the bottom of our OR shoes walking all over the hospital, right? So,
Yeah, rightly said. Yeah.
yeah, no, I do understand their concerns, not just from an infection prevention standpoint, but also the fact that, then somebody has to pick up these mats and clean them, and it's added burden on our cleaning environmental services staff and all of those things. So those things have to be looked at. But there's definitely enough of an advantage that this should be pretty much standard in any procedural area, not even in the operating room. You can use anti-fatigue mats during endoscopy, laparoscopy, whatever, even if you're standing at your desk, if you happen
Yeah.
to have a sit-stand desk, having an anti-fatigue mat is a great idea. So now comes kind of something a little bit more organizational, related. So you've started doing these things, and your colleagues and mentors and other institutions are doing these because they were part of this kind of survey, as I recall. I know that one of your trainees presented this data from your study at a national meeting, and they won an award, right?
Yes, yes,
For
yes,
bringing attention to ergonomics. So,
yes.
has that spurred any further conversations in sort of surgical leadership and program directors and maybe surgical societies in India? Regarding maybe like thinking about ergonomics curricula or educational programs or having some sort of written guidance regarding what should be standard in, operating rooms to improve ergonomics for surgical staff. I'm just curious, because we look at these things here. As you know, we have kind of the society members kind of initiated a curriculum that goes into what we call the SCORE program, and
Yes.
that's used by all the ACGME accredited residency programs across the US. So I just wanted to hear what impact your work had, at a more broad level.
Yeah. So obviously, like there is growing momentum for incorporating surgical ergonomics in surgical training,
Hmm.
and nowadays many conferences and webinars or national conferences they do try to have a surgical ergonomics talk in their program that is happening. Yeah.
Wow, good to hear. Yeah.
Yeah. And also on our local level, like in
Hmm.
Madhya Pradesh Association of Surgeons, here we also try to incorporate a surgical ergonomics lecture in our annual meeting.
Hmm.
And so people are like they try to implement these things, and surgical leaderships of associations also they are aware of these issues, and that is why now increasingly they are including in their like teaching
Hmm.
programs
Hmm.
via
Hmm.
conferences and webinars. And as we discussed that we have our national Indian Association of Endocrine Surgeons conference next year in Jabalpur, and we will also have a dedicated surgical ergonomics key lecture there, and maybe we can have a live demo because seeing a surgeon standing like a flamingo for 3 hours,
Yeah,
right?
that's right. Yeah.
Is more
Yeah.
educational than any PowerPoint presentation. So
I agree with you. I mean, I use video-based ergonomics coaching, along with my partner Linda Miller. And yeah, I mean, a 2-minute video is so telling, even for someone like me who talks about posture. Someone looks at my video, they're like, this person is talking about ergonomics. Look at her ergonomics. And my counter to that is, I'm aware when my ergonomics are bad, and I make sure I take more frequent breaks during that period of time. So, because as Dr. Hallbeck, who's kind of the guru of surgical ergonomics says, you can't be in a neutral posture all the time. So you have
yeah,
to be able to be aware of your posture and do the resets,
yeah,
by taking a break and exercising. But since you brought it up, I will share, and I'm happy to include this study in the show notes as well. I think shortly after our initial work in surgical ergonomics, one of our residents also wanted to do a survey of endocrine surgeons, and we have one of the highest rates of work-related musculoskeletal injury, and it's similar to kind of ENT surgeons, and it's multifactorial, right? There are many causes, but if you're working in as you said, kind of a confined space, so endocrine surgeons, ENT surgeons often working in very small spaces, so you end up in non-neutral postures for a lot of time. Often you're doing, you don't have a variety of procedures. Like sometimes you're operating in the neck, sometimes you're operating in the abdomen. Often you're in the same space, so it's the same repetitive, non-ergonomic work. So, and then on top of it, like you said, standing like a flamingo, I presume you're referring to wearing a headlight and then also standing with a foot pedal. So you're, standing like a flamingo on one foot waiting to hit the foot pedal, which
yeah,
really does nothing for maintaining a neutral posture. And of course, not to mention the weight of the headlamp, which we all like to use in small spaces. So all of these things add to the ergonomic risk. So, in the last few minutes, I'd like to hear kind of what specific adjustments you've done, not the general things that we've already talked about, but how have you changed your adjuncts and, what you do for endocrine surgery as well as breast surgery. And I ask this because I know that you've made some significant changes in how you do thyroidectomies, including, as I recall, doing thyroidectomies under the microscope, similar to what Phil Haig talked about and published at the AES meeting a couple of years ago.
Yes, yes, yeah. So, as you rightly said, that as endocrine surgeons, we are at very high risk of like musculoskeletal injury because of all those reasons you just explained. So, to change that, we adopted using microscope during recurrent laryngeal nerve exposure and preservation step of the thyroidectomy, because that is the one crucial step where we tend to bend our neck so much to see
Mm-hmm,
the
mm-hmm, mm-hmm.
recurrent laryngeal nerve. So I discussed this with Phil, and then we also started using microscope, and it really helps us. And we are currently doing a study on that also,
I
along
see.
with Phil. Yeah,
Phil.
collaborate.
Mm-hmm, mm-hmm.
So that is a simple thing which we have implemented. And then apart from that, like being conscious to your posture is important. So once you are aware of the ergonomics, you consciously try to correct your posture. As you said, it is not always possible to be in neutral posture, but you try to regain your neutral posture after few minutes of the surgery. So that also helps a lot.
Right.
So yeah.
Okay. So I'm interested in following up a little bit more on the microscope work. For our listeners, I will include the paper that Dr. Philip Haig, is an endocrine surgeon at Kaiser in LA, had published a couple of years ago about using the microscope. And the advantage there during thyroidectomy is that you can actually get rid of the headlight because you have lighting from the microscope, as well as get rid of the loops. Now, Sanjay, I don't know if you were already wearing loops. Were you wearing loops before using the microscope? No.
No, I avoid using loops because of neck pain. So I have stopped using loops
Right. I
totally.
stopped using loops many, many years ago as well because of neck pain, but I'd already used them for close to 16 years, so the damage was done. That being said, we'll come back to the topic of the loops. What I wanted to say was that, briefly, that there are different types of loops that you can use now. They're lighter loops, and they also have what they're called deflection loops, which is almost like looking through a microscope. So for some surgeons and certain kinds of surgeries, they're much more helpful than the traditional Galilean loops that we used to use. But you got the advantage with the microscope. You and Phil described having the advantage of both magnification and light, right? And those two, meaning wearing loops and headlights, are the two big risk factors for increased ergonomic risk. So you got rid of that by using the microscope. And so, do you use the microscope in every case for the nerve dissection, or do you only use it selectively?
So we use it selectively only,
Okay, okay.
not in every case, but for the purpose of our research,
Mm-hmm,
we try to do it. So in that research, we are trying to see
mm-hmm,
the open surgery
mm-hmm.
versus microscopic dissection versus endoscopic thyroidectomy,
I
which
see. Okay.
which is most ergonomic for endocrine surgeons. So far, the result is clear that microscope is the best for ergonomics for us.
I see.
And
I will look forward,
yeah,
yeah, to that publication.
yeah. So other advantage is that you don't have to bend your neck. So you microscope will be right near your eyes, and you can see that. So you don't have to bend your neck.
Okay, great. Well, since you brought up endoscopic, thyroidectomy, I have to ask about the other minimally invasive technique, which is robotic thyroidectomy. Is robotic surgery available in India at your center or other centers? And do you have experience doing robotic surgery, particularly robotic endocrine and thyroid surgery?
Yeah, so it is not available here, and I have
Mm,
not done robotic thyroidectomy, but many centers in India are doing it. But I don't know how, like, if it is more ergonomic than
okay,
endoscopic or open thyroid surgery. That is one particular area of research which could be very interesting for us to.
okay. Yeah, no, I was just curious because I didn't know what the access was at your center, but that makes sense. Well, as I mentioned earlier, I'm going to look forward to t looking at the results of this study, and I'm glad to hear that you and Phil have been collaborating on this. And, I certainly it makes it easier to access the microscope than it is to access the robot at many institutions.
Yeah.
The third thing that you mentioned in the flamingo posture is obviously the foot pedal. So what have you done about that? Are you getting rid of the foot pedal? Or are you still using that?
Unfortunately, we have to use that. So we are using that,
Okay.
but we'll, we'll try to get away with it as soon as possible.
Okay. All right. Get rid of it. I got it. So, I'll share with you and our listeners when I was looking into this for a coaching client of mine some time ago. It was not related to endocrine surgery, but, it depends on what you're using. For certain kinds of foot pedal, whether you're using an energy device or cautery, you can actually look at attachments that will convert the foot pedal to a hand control, just like you would have with a hand control cautery. So it's worth looking at it if it might work in your particular situation and seeing if just taking that out of the equation, might make a difference. With all the things you've already changed, it may or may not make a difference, but certain kinds of energy devices and cautery can be switched to the hand control mode. So something to look
No,
at.
that's really good advice. I mean, I have to see that.
Okay.
Yeah.
I'll see if I can find the link that I had shared with one of my previous clients and see if, you might be able to find something equivalent in India. Okay.
Yes, yes, great. Thank you.
All right. I say this every week and I'll say it again. I'm always amazed at how quickly the time goes when we're recording these episodes because we're sharing kind of ideas and we're talking with like-minded people. And so time just seems to fly. So we're almost at the end of our kind of time set aside.
Yeah, because as you told that we will be recording for 45 minutes, I said, oh, what will we talk for 45 minutes on
Well, now
ergonomics?
we've got 45 minutes. So I'm just kind of, in the last minute or so, I just want to make sure that I express my thanks once again to you and your colleagues and residents for being part of those studies, and especially you for being willing to be a guest here today. I know it's later for you in India this evening, and it's probably your a little bit past your bedtime. And so I'm really appreciative that you took some time out from your busy schedule to share, your journey with pain and, resulting in your discovering or learning more about ergonomics, and then all your efforts to kind of share it, within the surgical community that you work in, in India. So thank you for being a part of this today again, and for also being a part of the society and leading the membership committee along with Dr. Haig. So,
No, thank you, Geeta. It all started with that surgical ergonomics interest group, and so we have come so far. And
right,
thank
right.
you and Society of Surgical Ergonomics for keeping the momentum.
Yes,
And
yes.
yeah, as it can be said that a healthy surgeon is the best surgical safety checklist, right? So with
It is.
that,
That's a great quote. Thank you for sharing that. No, you're absolutely right. And I'm so glad that these conversations are happening everywhere. Just today, I think I sent you an article from Doximity where, we're talking about surgeon injuries and how, they're almost comparable to those that we sometimes see in, people who we think have high risk of injury, like construction workers and other blue collar workers. So I'm glad that we're having these conversations, and hopefully things will just continue to improve, because there are things we can do here to intervene.
Yes.
Well, Sanjay, our time today has almost come to an end, so I wanted to take a moment here to thank you for joining me today on the Surgical Ergonomics podcast and sharing your experiences with implementing ergonomic best practices in your neck of the woods. Please remember to subscribe to the podcast and follow us on social media: Instagram, X, Facebook, and LinkedIn. We love feedback, so please reach out to us for topics, ideas, speakers, or if you ever want to be a guest on the show. Thank you for listening. To enter your name for the Ergo Angle Deflection Loops and Headlight Combo giveaway, please go to our podcast landing page at www.surgicalergonomics.com/podcast/ and fill out the contact form at the bottom of the page. Choose Other in the drop-down menu and indicate Loops giveaway in the message. We will do a drawing for the winner in December of 2025, so please spread the word among your colleagues and friends who might be in the market for new loops. Thank you.